Assalamu alaikum. MashaAllah, very rich morning. We move to very exciting session about cardiomyopathy. We have three great speakers. We're gonna, one of them talk about dilated cardiomyopathy, the other hypertrophic cardiomyopathy, and the third one, very interesting topic about peripartum cardiomyopathy. So the first speaker is Dr. Taha, and Dr. Amira Taha is consultant cardiologist with special interest in cardiac imaging and cardiac MRI. And she will talk about a case of dilated cardiomyopathy in athletic person. Thank you, Dr. Taha, please.
Assalamu alaikum. Thank you for all for your valuable attendance, and thank you for the organizing committee and Emirates Heart Society, especially Dr. Abdullah Shihab. Special gratitude for Dr. John Paul Carpenter for his constant support and help in cardiac MRI patients, especially in this patient. Let's start our challenging subject, which is how to differentiate findings for dilated cardiomyopathy with high endurance trained athlete. Sorry. Yeah, our case presentation. Okay, thank you. We got 33 years old gentleman. He's working as a military officer. He actually came for preoperative assessment for minor surgery, orthopedic surgery. And by the book, already, I know that we shouldn't do an extra investigation like echo because he was asymptomatic. At the beginning, he told that he's asymptomatic, his function capacity is very good. And besides his military training also, he's doing all types of high endurance training like jiu-jitsu, swimming, football, everything he's doing, and he denied history. Okay. Yeah. He denied any history for anabolic hormones or drugs at time being, but 4 years back he was doing that. And he denied any symptoms suggestive of heart failure. But on stress of, because I saw him, he's muscular athlete, and he has family history of coronary heart disease. I stressed for his symptoms. He mentioned that he has mild shortness of breathing last month only. And here is the vital data for him. This his ECG, and actually the anesthetist sent him for preoperative assessment for this ECG, which show no significant changes. It's only like a high G point, and of course bradycardia. So at this time, I don't feel comfort for this patient. So I started with echo. But because the echo will take more time, so let's see the other investigation first. I did for him Holter 24 hours, so it showed only the bradycardia and atrial extracentric. And this is his chest X-ray. His lab was remarkable for cholesterol, and he doesn't know about this. His LDL is 6.1. And pro-BNP, it was normal. Other lab was in normal range. And this is his echo. Let us take some details in this echo for chamber, short axis, and parasternal long axis. And this is the measurements for, here we will see the left ventricle in diastolic dimension is 6.2, and his estimated ejection fraction around 46%. And this is the other images, 2 chambers, 3 chambers. And diastolic function estimated is normal for him. And this is being normal with athletes, the diastolic function being normal or hyper even. And this is the TAVI, the TAPSI, it's around 1.9. Here, the most a remarkable change in his echo. I did for him peak systolic longitudinal strain, and it showed -9, which is so low for athlete and for normal, of course. Okay, after echo, I was already confused. Is it only athletic changes, or we need more investigations to rule out dilated cardiomyopathy? Because of course, in all of us meet athletes was not like this picture of LV dilatation. So this is his cardiac MRI, which showed severely dilated left ventricle and right ventricle. And also the left ventricular end-diastolic volume, index volume, is 126 milliliter per meter, square meter. And this is above normal for athlete. Even high endurance athlete, the end-diastolic volume index, it's around 100 milliliter per square meter. And also for athlete, the LV mass is more than this, because of course there is LV hypertrophy, but for our patient, we didn't find any increase in LV mass. And for T1 and extracellular volume is within normal, and estimated ejection fraction with the MRI was around 48%, and for RV it was around 54%. And this is the graph showed that the normal variant according to the age for the LV diastolic function and indexed with the body surface area. This is the red dot is our patient level, and of course it's very high according to his age for normal or for athlete patient. And the ejection fraction is so low also for athlete, because most probably athlete patients showed ejection fraction around 50, maybe 55, not less than this. And this is a cardiac MRI showing stress. The above is the stress, and down is the rest. Showed no stress-induced ischemia, and also no criteria for myocarditis. Sorry. The MRI report showed that this collected data is going with cardiomyopathy, the late cardiomyopathy phenotype, and it's unlikely to be only athlete heart. So we came in conclusion that this patient, it could have dilated cardiomyopathy phenotype, and I start treatment as this. And it was very challenging because the patient was reluctant to stop his training and was reluctant to start treatment. I put him in anti-failure measure since, as we told before, the 4, like our discussion yesterday. And I put the medication only for 1 month, just to see him in follow-up after 1 month and up titrate the doses. But unfortunately, patient was so reluctant, he didn't come except after 3 months. And at that time, he mentioned that the 1 month he took the medicine, he saw that he has no symptoms, but after the medicine taken at the first month, he told me that he feel more comfort during exercise, and I was astonished why he didn't stop exercise, of course, as I stressed on him. And after 3 months, we repeat everything, ECG, echo, pro-BNB, all normal, but unfortunately, the ejection fraction came low with the echo. It was around 30 to 35%. So I stressed on him to start the medicine again and stop exercise completely, and have genetic counseling and screening for first-degree relatives. And this is a comparison between the first echo and the echo after 3 months. Of course, not in treatment. The ejection fraction is different. Here it was like 48 or 46%, and here the ejection fraction was 30 to 35%. I took many measurements for ejection fraction because really I was astonished that this declined in 2 months only. Here by Blaine method and also in mood, it was all the same. It's like 32%, 35%, and the left atrial dilatation is more. And here's the benefit of 3D echo. Sometimes you feel that you want to take many measurements to be accurate with ejection fraction, and 3D echo offers that here, but it gives the ejection fraction like 26%. And of course, the global longitudinal strain is the most effective way to say. Here also still, like we see in the picture, all pale red, it's around -10, -13 in all segments. So here is our review why it's crucial to differentiate between dilated cardiomyopathy and only athlete heart. Because the dilated cardiomyopathy, it carries a risk of sudden cardiac death, as all knows. So it's crucial to differentiate between pathological finding and physiological. And there is a stepwise diagram that showed that we have first step, second step, and third step. Of course, the first step, it will be like family history, clinical examination, any history of family sudden cardiac death. And also ECG. So here there is the definition. They mentioned that at least 3 hours of training per week, at least 3 months, it could give sufficient for morphological changes called the athlete heart. Here's a stepwise approach. At the beginning, first line, personal history, family history, of course, and ECG, and physical examination. If we suspect something, of course, we will proceed to the echocardiography and 24 hours Holter. If it's not enough for me or I suspect something, we can use exercise test, exercise echo also, and of course, the gold standard cardiac MRI. And here's the difference between the pathological and normal changes for ECG for athlete heart. Of course, if we have like left bundle ST segment depression, T-wave inversion, this will go towards the pathological condition, dilated cardiomyopathy. And there is appropriateness for the change. Here's the normal, borderline, and abnormal. I think it's the same. There is only increased epsilon wave, brugada, profound sinus, bradycardia less than 30, and PR interval more than 400 milliseconds. And of course, heart block. So our echo also, this is just diagram for the normal changes in athlete heart, which is different than dilated cardiomyopathy. Here is the stroke volume index and the gadolinium, and global longitudinal strain, all within normal. Also, there is LV dilatation, and of course, there is balanced LV and RV dilatation. Also, our echo in diagnosis, we have more advanced techniques like speckle tracking, and which showed the cut point for athlete is around -18, but for patient with dilated cardiomyopathy is -13. And we have also, like we saw in the other slide, 3-dimensional echo. This is the speckle tracking for the athlete, even the high endurance athlete. We show that all around 21, -22, -20. So it's a way difference from dilated cardiomyopathy. Here is a rule of exercise echo. They mentioned that if we do exercise echo for the patient and the ejection fraction didn't increase more than 11%, or it didn't reach 63% ejection fraction, so it's more favorable for dilated cardiomyopathy. Our stress test, exercise test, we are using only for blood pressure, because if the blood pressure becomes so low or hypotension during the test, so it's favorable for dilated cardiomyopathy, not athletes. With athletes, it will increase. For Holter, of course, we will show any arrhythmia, especially ventricular arrhythmia. And this is a criteria for some BVCs. If with the right bundle more than QRS more than 130 millisecond, or left bundle, it will be favorable, polymorphic, favorable for dilated cardiomyopathy. So the third line evaluation, if I couldn't take any clear image for first or second line, so we'll proceed the third line, which is cardiac MRI, exercise stress echo, cardiac CT for coronary, and nuclear imaging for functional assessment. And the genetic test, of course, is the accurate test if you found the gene. For cardiac MRI, of course, it's the gold standard for this diagnosis because it diagnoses structural heart disease, and also it showed the T1 and T2 mapping, and of course the late gadolinium enhancement. Here, the late gadolinium enhancement in 50% of dilated cardiomyopathy patients, it will be negative. So that means that if I find late gadolinium enhancement is negative, this is not conclusive that it's not dilated cardiomyopathy. And this is a CMR of an endurance athlete, not dilated cardiomyopathy. This showed the difference in between athlete heart and many types of cardiomyopathy. Of course, the most famous is hypertrophic cardiomyopathy, but here there is a differentiation between all. And we'll see the dilated cardiomyopathy is the LV is severely dilated and loss of triangular shape for the LV. And for genetic in dilated cardiomyopathy, of course, we have like 40 genes differentiated for familial or genetic cardiomyopathy. But unfortunately, also, there is some genes we couldn't be isolated. So also sometimes the genes analysis come negative. Our conclusion that we should have specific figures and the criteria for differentiation between dilated cardiomyopathy and dilated cardiomyopathy in athlete heart and athlete heart as normal physiological changes, because this gray zone will be depending on how to manage and how he will stop training or no. And of course, there is detraining period. If we suspect and still we are not sure, we'll tell the patient for detraining period around 6 months. After that, we repeat the echo and cardiac MRI. If it's normalized, so it means that this was physiological process. Thank you.
Thank you so much, Dr. Taha, for a very challenging, very well presentation. Do we have time for one or two burning questions? Then we can move on with my co-chairman to the next speaker. If not, we can still ask questions at the end. Thank you so much. Dr. Rami.
We'll move on to the second session with our esteemed colleague, Dr. Imad Musa, who's the head of radiology at Mediclinic Airport Road. He's gonna talk about the CMR and risk stratification in hypertrophic cardiomyopathy.
Assalamu alaikum. So I'm going to present the CMR diagnosis and risk stratification of hypertrophic cardiomyopathy. So next slide, please. Excuse me. Okay. So as we know, hypertrophic cardiomyopathy is probably the commonest genetic cardiomyopathy. It is present in 1 in 500 of the population. There is more than 1,400 of possible genetic mutations that lies behind hypertrophic cardiomyopathy. And these are actually involving the 11 sarcomeres, which controls the myocardial wall formation and thickness. The disease is quite prevalent. The majority of patients actually will have a normal life expectancy with no complications, but a small but still significant proportion of those patients might actually develop devastating complications, including complications as systolic heart failure, arrhythmias, thromboembolic episodes, and sudden death. So I'm now presenting 6 types of patients in cardiac MRI to see the different patterns. As in A, we can see extensive septal hypertrophy that is exceeding 30 millimeter in thickness. This is by itself is considered a high risk factor for sudden death and is an indication of an ICD placement when we exceed a thickness of 30 millimeter of the myocardium. The second patient in B, we can see an infraseptal extensive atrophy. In C, we can see a patient with mild anteroseptal hypertrophy involving the anterior septum of the base level. That patient could be difficult during echo because of the anatomy and because of the limitations of echo as compared to MRI. As we go down to panel D, we can see a patient with extensive form of apical hypertrophy involving the mid and apical zones of the left ventricle. But now, as we go to patient E, we can start seeing an uncommon forms of hypertrophic cardiomyopathies, because in hypertrophic cardiomyopathy, it doesn't just mean the hypertrophy of the myocardium. It could also mean other morphologic patterns other than hypertrophy. So in patient E, for example, what we can see here, that there is a hypertrophy of the anterolateral papillary muscle, which is a well-known morphologic feature of hypertrophic cardiomyopathy. That's an isolated form. Not only that, but we can see that the muscle itself is actually anomalous, and it is inserting an anomalous insertion in the anterior mitral valve leaflet. By itself, this is causing a systolic movement of the papillary muscle, obstructing the left ventricle outflow to the aorta. That's a morphologic pattern of hypertrophic cardiomyopathy, which can be better understood if you do a CMR examination. Finally, in patient F, we can see another form of morphologic presentation of hypertrophic cardiomyopathy, which is the left ventricle myocardial crypts. This is well-known, isolated feature of hypertrophic cardiomyopathy, which actually might be the only morphologic feature of the patient. So, as in the role of magnetic resonance imaging, we know that MRI is now becoming the gold standard because of the superiority in resolution and ability to differentiate between the blood pool and to give a better measurement of the myocardium. Not only a better measurement, but a better follow-up also, as we can see, and because in many patients we will need a follow-up evaluation over time and also evaluation of the family members' first-degree relatives. So relying on accurate measurement of the diameter and thickness, this could be a very powerful strategy to do your follow-up for the patients. Additionally, we know now that MRI can depict the different morphologic patterns, which is uncommon in patients of hypertrophic cardiomyopathy. So now we see an example. This is a patient who had presented with abnormal ECG, showing right bundle branch block plus some Q waves in different locations. Because of the abnormality of the ECG, the patient went to do an echo, and the echo, as we can see, was actually quite challenging, especially in the anteroseptal region, which was actually marked as questionable. It was not trustable whether it is abnormal or having something. So the patient went into MRI, and we can see the more superior quality of CMR in depicting the wall thickness and the abnormality, with extensive anteroseptal segment thickening exceeding also 30, which is by itself, as we said, is an indication for the ICD placement. In many examples, the echo by itself can be an exaggerating factor during the performance of an echo. As this example, which is quite common. So this patient did an echo, and it was described that he has an extensive anteroseptal thickening. On MRI, we can see that the reason for this was the crista supraventricularis anatomical muscle, which is part of the lumen of the right ventricle. It is not part of the septum. So by this anatomical superiority of cardiac MRI, this patient was marked as a milder septal thickening, which of course will change the management of this patient. This is another example of a patient who is already having an extensive anteroseptal hypertrophic cardiomyopathy plus extensive hypertrophy of the crista supraventricularis. Now, in an echo, you might not be able to differentiate between the septum and the muscle can be actually included in the measurement, which will result into faulty interpretation and, of course, management of the patients. Now, going to the next point of the diagnosis, which is assessment of family members. As we know, all first-degree relatives of hypertrophic cardiomyopathy patient should go for screening. And because of the superiority of cardiac MRI and its ability to do that and to identify the thickness and follow-up of it, so we start at adolescence, and the interval of follow-up is actually 2 years from the beginning of adolescence until adult age, and then every 5 years until the 4th decade, because we know that there is a possibility that hypertrophic cardiomyopathy might actually be late onset in the presentation. Of course, we know that genetic testing is maybe not always covered by insurance, and it actually might be very commonly negative, but we will see that in many of the cases, MRI can give you a positive phenotypic presentation of hypertrophic cardiomyopathy, while still you have a genotype negative patient. And as we said before, cardiac MRI might actually give you atypical patterns of phenotypic positive and might prove that one of the family members carry a positive phenotypic pattern, which will alter your follow-up strategy and evaluation of this relative. As in this example, this patient was a relative of a victim of sudden cardiac arrest and HICOM. So in evaluation, echo was normal. Parents insisted on doing a cardiac MRI, which was described as being superior. And in cardiac MRI, we can see the left ventricle myocardial crypts. These myocardial crypts is actually a phenotypic feature of hypertrophic cardiomyopathy. So it changed the patient from phenotypic negative into a phenotypic positive, which means that this patient will be different in terms of the follow-up, etc. This is an example of another morphologic features of hypertrophic cardiomyopathy. This is a diagram showing anomalous long anterior leaflet of mitral valve. And again, this is now considered as one of the morphologic features, phenotypic positive features of hypertrophic cardiomyopathy. So in this patient, as we can see, cardiac MRI is demonstrating the abnormally elongated anterior leaflet of the mitral valve, which is again by itself considered as a morphologic feature of HICOM. As we saw now in the previous lecture, now there is mapping of the myocardium, and in the mapping of the myocardium, we don't do qualitative evaluation of the myocardium, which means we look to the myocardium entirely by signal through a qualitative evaluation. But what we do is we do a quantitative, or rather quantitative evaluation of the myocardium through calculation by pixel for the myocardium. And in this aspect, we can get numbers, and we transfer the number into a color-coded map. We know now that every disease having its own presentation and its own behavior in terms of the T1 mapping, which is a measurement of the extracellular volume. It could measure the iron load. It could measure the percent of fibrosis in the myocardium. And then we have the T2 map, which is more for the edema of the myocardium in acute insults like acute inflammation and myocarditis, or sarcoidosis, or acute insults, or aggravation of a disease. In a term that T2 is more about the activity of a disease and the degree of acuteness of a disease. And finally, we can also calculate the T2 gradient, which is a calculator of the iron load in cases of hemochromatosis. In this patient, the first row showing the value of T1 mapping of the myocardium in cases of hypertrophic cardiomyopathy. This is the color map of the native T1 without using contrast. And this is the late gadolinium. And as we can see in the uppermost antroseptal, we can see the late gadolinium showing patchy intramyocardial fibrosis, indicating the fibrosis, which is a specific pattern. And in this type, it is very highly linked to hypertrophic cardiomyopathy. But when we go for the calculation of extracellular volume, we can see that the color-coded map is actually showing much extensive areas of abnormalities, which are all presented here in reddish. This is an areas of abnormal extracellular volume, much bigger and beyond the areas of late gadolinium enhancement. This is very important because it identifies the extent of the disease and how the disease is actually involving the cardiac muscle, and it can actually give you an idea about the future perspectives of this patient. If this patient is going to develop a heart failure in the future, what about the risk? This is, again, is an area under extensive studies to identify the effect of extracellular volume and effect of abnormalities of T1 in your decision to put this patient on a waiting list for cardiac transplantation in the future for extensive patients. Also, an important area of the diagnosis is differentiation from other etiologies of hypertrophy of the myocardium, like doctor said in the previous lecture, athletic heart, for example. We know that athletic heart, there will be more of asymmetric diffuse hypertrophy of the myocardium, unlike hypertrophic cardiomyopathy, where you have an asymmetric form of hypertrophy. Here we have an example of an NBA player. This player actually presented with a abnormal heart rhythm, etc., abnormal ECG, and then went for cardiac MRI. In cardiac MRI, the initial cardiac MRI at the baseline demonstrated a questionable infroseptal mild thickening. The late gadolinium enhancement, which in the last image showed subtle patchy enhancement at this infroseptal segment. So the question at this phase was, is he having an athletic heart disease or hypertrophic cardiomyopathy? So this patient went into a deconditioning where forced resting for 3 months, aiming to look for the effect of deconditioning. And at 3 months exactly, remeasurement of the thickness of the hypertrophied segment was done. And as we can see, there was no difference between the two studies, the initial study and the follow-up study after deconditioning. So the conclusion is that this is hypertrophic cardiomyopathy rather than athletic heart. The normal expectation in athletic heart is that the myocardium will regress by 2 millimeters in thickness following a forced deconditioning for 3 months. And as doctor said, 3 to 6 months. So of course, this is an example how this MRI have managed to change the prognosis of this patient, changing him from one diagnosed to the other. Again, we have hypertensive cardiomyopathy, and just for summary, hypertensive cardiomyopathy is also managed in the same way. Usually, you will have asymmetric diffuse left ventricular hypertrophy, and if you do a baseline study and then you do aggressive treatment of hypertension, your expectation is that the myocardium will regress by 2 millimeters in thickness following 3 to 6 months of aggressive antihypertensive medications. You need to make sure that your medication is actually working and the pressure goes back to the average acceptable values, and repeat the MRI again after 6 months, looking for the thickness of the myocardium as a response. In those cases where there is no response, you should raise and be alerted about the possibility of hypertrophic cardiomyopathy, even if the patient is genonegative. Other types that worth differentiation, and you as cardiologists will meet always in your practical life, is the infiltrative cardiomyopathies. The most common is amyloidosis, which causes extensive hypertrophy of the myocardium. We have also Anderson-Fabry disease, which is lipofibrotic infiltrates of the cardiac base. It is an enzyme-mediated genetic X-linked disease, but it is basically curative. There are enzyme replacement therapy. And then you have also other diseases like Danon disease, etc., which is an infiltrative vascular disease, which is actually an early presentation in young adult, and it is fatal disease. So this is an example of the presentations of different cases in cardiac MRI. The first case where we can see extensive hypertrophy of the myocardium involving mostly the inferior wall, the infraseptal, slightly on the lateral wall. It's a little bit asymmetric. Nothing against being hypertrophic cardiomyopathy, right? But when we do a delayed gadolinium enhancement, we can see an extensive late subendocardial enhancement involving the entire heart. This is a case of amyloidosis, and this is the typical pattern of cardiac amyloidosis. On the second row, we can see a patient who is also having septal hypertrophy, slight lateral wall hypertrophy. This is the base level. And on delayed gadolinium enhancement, we can see a very specific pattern of Anderson-Fabry disease, which is a subendocardial infralateral basal enhancement of the left ventricle. So this is a very specific pattern of Anderson-Fabry disease, and it should raise the concern and the differential diagnosis to elicit your testing for that possibility, which is essentially a curative disease. And then we have...
The time, Doctor.
Please, Doctor.
The time, yes.
Oh, okay, I'm trying. Then we have this patient with extensive hypertrophy, and then looking to this, we can see an extensive transmural enhancement. This pattern actually, which is involving the subendocardium and through the whole thickness of the myocardium, this pattern actually is not typical for hypertrophic cardiomyopathy, but it is more common with the Danon disease. Then we have also patterns in hypertrophic cardiomyopathy which we need to know. This is the mid-ventricular associated with a ventricular apical aneurysm. This is quite common, and by itself, it's a risk factor indicating the ICD placement. Here we can see the left ventricular apical aneurysm with a thrombus formation in the lumen. Another pattern which is very important, which is the septal hypertrophy associated with SAM. If you focus here, and I try to make the video go slower, we can see that during systole, the anterior leaflet of the mitral valve is actually causing the left ventricular outflow obstruction. So this SAM pattern, again, is easily diagnosed by MRI, and it will push you to decide what you need to do about the septum, septoplasty, alcohol injection, or what is your options in this. Finally, we reach a risk stratification, and this is a quite important point. I think this is a classical pyramid of risk stratification that you commonly use. If you have a primary patient with cardiac arrest or sustained VT, you go to the ICD, the secondary, etc. But what we want to say is that MRI now is becoming the most powerful indicator of ICD placement through the detection of fibrosis and scarring in the left ventricle, which is around 15%. It was found that this study showing 15% and more, very powerful indicator for ICD placement. Let's also remember that in practical life, and I think me and Dr. Andron have worked in many cases like this, the late gadolinium enhancement might be actually the only factor that push you to take the decision for ICD, other than clinical presentation. Finally, for systolic dysfunction, which is a risk stratification. Please.
We have to really end up.
Sure, doctor.
Actually, this is such important topic, which we need an hour at least. So this is unfair. I'm sorry they gave you only 15 minutes. So thank you so much. We move on to the last, not the least, the presentation. And then I'm sure we will have, I want the speaker to stay around, but there will be a lot of important questions for those who have it later on. Thank you so much, Dr. MashaAllah. Okay, last but not the least, the presenter about very important topic, the management of peripartum cardiomyopathy. Dr. Abu Bakr, consultant cardiologist, and this is a very challenging and very important topic. And thank you, doctor. Please go ahead.
Assalamu alaikum. Dear colleagues, Mr. Chairman, it's a pleasure for me to share in this meeting, and our topic today is peripartum. Peripartum cardiomyopathy is a form of systolic heart failure with reduced ejection fraction that occur in women during the last trimester of pregnancy or in the first 5 to 6 months after in the postpartum period. As per the European Society of Cardiology Working Group at 2010, the definition, the Diagnosis is based on 3 criteria, which is development of heart failure towards the end of pregnancy or in the months following delivery, in absence of another identifiable cause for heart failure, and with ejection fraction less than 45%. The incidence of the peripartum cardiomyopathy is different in different parts of the world, reported as high as 1 in 100 delivery in Nigeria, reported as low as 1 in 20,000 delivery in Japan. In the United States, it was reported to be in the range from 1 per 1,000 to 1 per 4,000 delivery. The risk factor for development of peripartum cardiomyopathy, it's common in women of African race, in those who have preeclampsia or hypertension, in multigestational pregnancy, and in older maternal age more than 30 years old. What about pathophysiology? Although a complete understanding of the etiology of peripartum cardiomyopathy is still ill-defined, many potential causes have been suggested, including genetic predisposition, myocarditis, either viral or autoimmune, malnutrition, and oxidative stress and prolactin theory that we'll discuss in more details. It was shown in animal models that oxidative stress triggers through an unclear mechanism cardiomyocytes to express a protein called cathepsin D, which in turn enhances the conversion of prolactin into angiogenic, anti-angiogenic, and pro-apoptotic 16 kilodalton derivative. This induces more injury to the myocardium. This theory was further reinforced by beneficial effect of blockade of prolactin secretion with bromocriptine in some limited studies. This is a demonstration of what we called this prolactin secreted in excess by the last trimester and during puerperium. Increased oxidative stress make myocardium excrete cathepsin D, and this result in degradation of prolactin, and this degradation product can harm or make injury to the myocardium through apoptosis and anti-angiogenesis. Presentation of the peripartum cardiomyopathy typically develop in the first month of postpartum, but it can occur in the third trimester or up to 6 months of postpartum. Most patients present with typical heart failure signs and symptoms, but some present by the complication, either thromboembolism, life-threatening arrhythmia, or even first presentation would be sudden cardiac death. The outcome is different. It ranges from complete recovery to persistent LV dysfunction with chronic heart failure, or it can have a fulminant rapid course of deterioration with cardiogenic shock and needs mechanical ventilation, mechanical circulatory support, and even cardiac transplantation. The risk factors for bad prognosis is primarily the ejection fraction at the time of diagnosis. If it is less than 30%, it's bad prognosis, but additional risk factors also are there, like LV dilatation, LV thrombus, right ventricular systolic dysfunction, obesity, African American ethnicity, concomitant preeclampsia, marked elevation of proBNP and troponin, and the presence of late gadolinium enhancement by MRI. It's known that peripartum cardiomyopathy have tendency for recurrence of LV dysfunction or deterioration of the LV function in further pregnancy. This occurs more on those who have non-recovery of ejection fraction, and the most bad prognosis or the most recurrence of LV dysfunction occur on those who have persistent LV dysfunction, residual, and those who have ejection fraction at time of diagnosis less than 25%. Our case presentation is a 41 years old patient from Morocco. She came to our emergency room at July 2019. She is gravida 3 para 2, and she came with picture of pulmonary edema. She came in severe shortness of breath. This is her X-ray showing pulmonary edema, as you see, and her ECG shows sinus tachycardia with left bundle branch block. This is her labs showing high propane B, high troponin, elevated creatinine and liver enzymes as well, but this improved on follow-up. And echo was done, and it showed LV ejection fraction of around 30 to 35%. No regional wall motion abnormalities apart from those of left bundle. She had moderate to severe MR, mild TR, and mild pulmonary hypertension. This is the echo. Sorry for the bad image. This is the only saved image in our system. Patient was diagnosed as acute heart failure, likely post-peripartum cardiomyopathy, but we had a differential diagnosis. Patient is diabetic, and possibility of ischemic cardiomyopathy or diabetic cardiomyopathy was there. Anyhow, we admitted to the ICU, BiPAP and the IV Lasix was started. Patient partially improved, but we discussed with the obstetrician. He took the risk to carry the patient to operation room and make urgent cesarean section. Patient was 37 weeks. And we discussed also with the patient and her husband regarding the prognosis, and they agreed for tubal ligation. So we put the patient in IV inotropes and mechanical ventilation, and she went cesarean section and tubal ligation. Post-operatively, patient had partial improvement, slowly improvement. So we started levosimendan, calcium sensitizer, and we started oral bromocriptine, as we discussed before. It showed some improvement in limited studies. And she was kept on full dose of low molecular weight heparin for the risk of thromboembolism known to be high in peripartum cardiomyopathy. Patient improved in this medication. We started the 4 pillars of heart failure medication in small dose after full hemodynamic stabilization. And we changed low molecular weight heparin to Xarelto as we stopped lactation. And CEG was done to rule out ischemic cardiomyopathy, as we said. It came normal coronary. Before hospital discharge, we repeated the echo. It showed some improvement of LV ejection fraction to 40 to 45%. Clinically, she had full resolution of heart failure signs. Gradual up titration of doses of beta blocker, Entresto, spironolactone was done as outpatient clinic, and it was well tolerated, together with SGLT2 inhibitor also. Her ECG changed to normal conduction on follow-up, showed resolution of left bundle, but we did Holter that showed she still has rate-dependent left bundle branch block and few isolated ventricular ectopics. As you see here is this rate-dependent bundle branch block. And this is the echo done after 3 months. It shows almost full resolution of LV ejection fraction to more than 55%. MR was reduced to only mild, minimal TR, and no pulmonary hypertension. Still, she has septal bounce of left bundle branch block because during the examination she had some tachycardia. And currently, patient is still on follow-up at our cardiac clinic. She's asymptomatic, no signs of heart failure. Follow-up echo didn't show any deterioration of LV function. Still, she is on the third pillars, beta blocker, interest to spironolactone and SGLT inhibitor, plus her anti-diabetic medication. Now, to go back to the literature for the recommendation for management of peripartum cardiomyopathy and heart failure during pregnancy in general and after delivery during lactation. The basic management plan is almost the same for non-ischemic cardiomyopathy, but we have some safety issues with pregnancy and lactation. As you see here, these are the safe drugs during pregnancy and lactation. Loop diuretics, beta blockers, especially metoprolol, hydralazine nitrates, digoxin are allowed during pregnancy and after delivery, also during lactation. But of course, all of us know that ACE inhibitor, ARBs, are contraindicated during pregnancy for teratogenicity. Aldosterone also and Entresto are not allowed. But for the postpartum period during lactation, ACE inhibitor ARBs are allowed. Enalapril and captopril are the most tested agents. It's safe. Spironolactone also allowed. But for Entresto and ivermectin, no enough data for the lactation, it's safe or not. Bromocriptine, several studies was done, but it showed inconsistent clinical benefits. So the American guidelines didn't put bromocriptine for the management of peripartum cardiomyopathy. However, the European Society of Cardiology put it as class 2B indication, maybe of benefit. Due association with thromboembolic event, increased thromboembolic event with bromocriptine, it should be combined with anticoagulant while using. And we should know that it will stop breastfeeding for those who is interested for value of breastfeeding. We should know if you use it, it will stop breastfeeding. This is the European guidelines. As you see here, indication for bromocriptine is class 2B indication, and combination with anticoagulant is class 2A indication. Anticoagulation in general is recommended for peripartum cardiomyopathy. The presence of LSB thrombus by echo was recorded in 10 to 17% of cases, and thromboembolic complication reported in 5 to 9% of women. Especially if the patient has LV ejection fraction less than 35%, it is more indicated. And if you have bromocriptine, as we said before, use bromocriptine, you have to start anticoagulation. And of course, if you find thrombus in the LV by echo. The warfarin is the preferred agent if the needed dose is below 5 milligrams. Low molecular weight heparin and unfractionated heparin are alternatives. But you should stop warfarin if planned vaginal delivery is there to avoid fetal intracranial hemorrhage during the delivery. NOACs are not considered safe during pregnancy, and during lactation there is limited data. I think apixaban is not indicated because it's coming in milk in good amount. Regarding the risk factor for sudden cardiac death, it is known that there is high risk for sudden cardiac death and malignant arrhythmia in peripartum cardiomyopathy, especially if ejection fraction is below 35%. But we should know that most of patients can recover LV ejection fraction, so it's not justified to put ICD early in the course of the disease. But some patients can develop sudden cardiac death during this period. So an alternative is to have a wearable cardioverter defibrillator during these early months postpartum. And only women with ejection fraction still low after 6 months of the full medical treatment for heart failure are candidate for ICD plus or minus resynchronization. Regarding subsequent pregnancy, the European Society of Cardiology guidelines discourage subsequent pregnancy if ejection fraction did not recover above 50 to 55%. But those who have recovered ejection fraction more than 50% still have some risk. So we have to have counseling with the patient and her husband and put the whole risk profile before taking decision for further pregnancy. This is my last slide, and it raises a very important question, but I don't know the reply for it, and you will show me for it. What is the time to stop medication for patients who recover LV function after peripartum cardiomyopathy? Those who have persistent LV dysfunction, sure, will continue the antifailure medication, but what about those who recover? Can they stop after some time? Some reports have described deterioration of LV function after partial or complete recovery, even in absence of subsequent pregnancy. So if you decide to stop medication or the patient cannot afford for the medication, for example, or something, if you stop, it should be stopped weaned in stepwise fashion with frequent clinical assessment and echo, initially 3 to 6 months interval, and then annually before to have, if you have any deterioration of LV function or new symptoms, you have to restart the medication, of course. And thank you.
Thank you, Dr. Muktas, for the wonderful lecture. Invite the panel, please. I'll invite the speakers and the panel to come up, please. Dr. Amira, please.
Thank you so much for everyone. I'm going to take the privilege of ask question until you guys are ready to ask more questions. So Dr. Ahmad, for that MPA player who was asymptomatic and discovered abnormal ECG and the echo showed septal hypertrophy, you put him no play for 3 months. Repeated the echo, showed the same, you made the diagnosis. What do you tell that MPA player after 3 months? Can he go back to play? What is the risk of sudden death? You put him on any medications? Is he candidate for ICD or what?
I will leave this for the cardiologist.
Oh, I'm cardiologist. I'm asking you. You don't know the answer because this is very high risk and the MPA player.
As a radiologist, I wouldn't talk to him actually about the management, but we will be in favor of the follow-up strategy for radiology from the radiology point of view. As a radiologist, I will take it from what to be done next. So an MBA player who discovered a positive phenotypic presentation of HICM, that's definitely a risk factor for sudden arrest, etc. Is he a candidate for an ICD placement at that case which we saw? No, he wasn't. We just discovered an ECG abnormality and he didn't develop blood pressure abnormality during abnormal blood pressure response. For example, he did not develop any one of the risk factors during an ICD. That's why from radiological point of view, our input that he has no risk factor for sudden death and he has no risk factor for expected heart failure. But we will recommend for him, of course, the follow-up strategy.
Well, I think this is controversial. I think it's unacceptable from cardiology point of view, with all my respect. So I raise it for really more input. So, Doctor, please.
Thanks a lot for the wonderful presentation and the cases, multitude of cases. I would like to highlight on the pentad of risk and the adjustment to the pentad of risk, which is 2014 calculator done by Mahoney and Perry Elliott at the Barts. The pentad is the inappropriate blood pressure response to exercise, family history, non-sustained VT, 30 millimeters, and collapse, 30 millimeters. So he did not fulfill that. However, there is an adjustment. So in the classification later on, the 2014, they took into consideration this late enhancement and LA size. They discounted the blood pressure response to exercise. It's not present anymore in that. So in such a patient, I would do prolonged monitoring. I will not put only just a Holter for 24 hours. I may implant a reveal device even if the week or 2 week Holter did not show anything, because I suspect that the sympathetic stimulation in such a guy may trigger VT. And as soon as VT, we should individualize in such a case. I think he will end up with an ICD.
Any question?
So, Rami, thank you very much indeed for that.
Yes.
JP Carpenter.
Dr. Carpenter is our colleague at the Health Point, and imaging as well, cardiac imaging, please.
Thank you very much. I was very interested in your comment because you've made comment about that ICD calculator with the European Society of Cardiology. And actually, the late enhancement doesn't appear on the calculator that you use. It's an interesting question. I'm sorry we didn't get to hear the whole of the end of that presentation about risk stratification, because that would have been very helpful. But there's clear evidence from Brompton Group, from Stuttgart, from other people, and there's ongoing studies, the HCMR registry, which is Europe, America, and different places looking at risk factors in HCM. How much should we rely on the presence or absence of late enhancement and the amount of late enhancement?
So as we mentioned, the late enhancement is actually present in roughly 30% of patients of HECOM, generally speaking, if you have hypertrophic cardiomyopathy. Now, the next step is actually quantification of the delayed enhancement as compared to the total left ventricular mass. And the studies showed that 15% of late gadolinium enhancement is actually associated with twofold increase of risk of sudden death. Not only that, the same studies also, another group of studies have shown that 15% and more of late gadolinium enhancement is associated with triple-fold increase in the risk of systolic heart failure over the next 6 to 8 years. So this became the mainstay in radiologic recommendations for ICD placement, and also early inclination of patients in cardiac transplantation programs, as in the US, where actually you need to take a decision much more earlier as a candidate for these patients. Again, this is an area under research, and there are many guidelines and studies are going on about the value of delayed enhancement. Even now, there is also extensive studies on T1 mapping and extracellular volume as a risk factor that can actually replace the importance of late gadolinium enhancement in assessment of the future of hypertrophic cardiomyopathy patients. So evolving studies, and but nowadays 15% late gadolinium enhancement out of the total left ventricular mass is the risk factor suggestive of ICD placement and suggestive of early inclination on cardiac transplantation lists.
So can I add something, please, as a conclusion for that discussion? I mean, Dr. JP, yes, that's what I mentioned in terms of prolonged monitoring, because that late gadolinium is not involved in 2014. So I would reckon that the MRI should be repeated in such a patient. So how often do you recommend, I mean, and after how long this MRI should be repeated? What do you recommend, like a year or 2 years or yearly, on a yearly basis?
I think first follow-up after 6 months.
6 months, yeah. Okay. Here you've done it after 3 months, right? In this case.
It was actually for deconditioning.
Deconditioning.
If
but
you are
I
talking
mean,
about the deconditioning.
Yeah, but we've seen that the amount of late gadolinium enhancement did not increase in 3 months.
It did not change,
it
but
did not change.
what we were basically looking for was the thickness of the myocardium. This was the case of athletic heart.
Yeah, sure.
So
sure.
you do the
Understood.
deconditioning and you wait for the thickness to reduce.
Yes. Okay.
Okay, Dr. Abu Bakr,
Dr.
there was here. Comment on the case of very challenging peripartum cardiomyopathy. And you said there are 3 categories. Those who have persistent LV dysfunction, who have recovered partially, who have completely recovered. And yes, as far as I know, we don't have the answer for whether we can stop safely all the medication. We don't know.
Yes.
And the other question, there is residual risk of possible recurrence of pericardium cardiomyopathy in completely recovered patients.
Yes.
So I think as clinicians, I think we can counsel them against premature pregnancy because if there is residual risk, if they have to understand it's their risk to accept if they really want kids, particularly in this part of the world, it's their risk. I don't think we can safely tell them, you're fine, go back, and unless you have other opinion.
Yes, as you said, it's a matter of discussion between the patient and her husband. For my case, she had 2 living siblings, and the fetus was expected to survive. So we discussed before the cesarean section that she will have a major chance for recurrence of the cardiomyopathy and the LV dysfunction. So they choose to have the tubal ligation for this because, as you said, even those who have full recovery of LV function, they can have recurrence of LV dysfunction and heart failure on subsequent pregnancy. So it's a choice for the husband, and if a woman have stillbirth and she's willing, she has no living children, she will choose to take the risk.
Well, with that, really, I think we come to conclusion of this very exciting morning and very important topic. And really, I want to thank the speakers. I want to thank all of you. And then, Mr. Chairman, you have anything before we go to lunch?
No, we're not going for lunch now.
Oh, no lunch, I'm sorry. Fasting today. Okay.
We still have some sessions, and
Okay.
then we will have a great lunch, inshallah.
Thank you so much for everyone.